Hello. Thanks to everyone who's joined us for our Advocating for Prevention in Communities of Color, the Role of Providers Amid the Opioid Crisis webinar this afternoon. My name is Juliet Bowie, and I'm from the HHS Office of Minority Health, and I'll be your moderator for today's webinar. So before we begin, I just want to go over a few housekeeping items. First, this webinar is being recorded, and you will receive an email after the webinar, which includes a link to the recording, which will also be posted to our YouTube channel. All the participants are going to be automatically muted throughout the duration of this webinar, but we will have time for questions after our last presentation. So please feel free to submit your questions at any point during our webinar via the chat box, and we'll try to get to as many questions as possible. And then finally, to request the slides, please email info@minorityhealth.hhs.gov. Today, we're so excited to have 3 presentations from experts focused on the prevention of opioid misuse, addiction, and overdose. So welcome and thank you to Dr. Amy Goldstein, Dr. Donica Brown, Dr. Ingrid Binswanger, and Dr. An Nguyen. But before we get to our expert presentations, we'd like to provide some context for why these issues are important for providers serving racial and ethnic minority populations and how the opioid crisis is impacting communities of color. Next slide. Next slide, please. To share this background and to kick off our webinar series, I'm honored to introduce Captain Felicia Collins, Deputy Assistant Secretary for Minority Health and Director of the Office of Minority Health at the U.S. Department of Health and Human Services. Captain Collins.
So thank you very much, Juliet, and a hearty welcome to all of you that are participating in the webinar today. Really excited for this opportunity to share a little bit with you, and I'm very, very appreciative of your participation. Next slide, please. What we thought we would do was first provide you with a brief overview of the Office of Minority Health in case this is new to some of you. And as Juliet mentioned, I am the new Deputy Assistant Secretary for Minority Health and Director of the Office of Minority Health. And in this role, it's been really important for me to review the mission of the office over and over to myself and with others as I've had the opportunity to meet with people, because I find that the mission is really important to ground myself and others in the work in which the office is charged. And so the mission of the Office of Minority Health is to improve the health of racial and ethnic minorities and vulnerable populations in a nutshell. And we do this through developing programs, policies, and partnerships that help people we serve improve their health and their health care. Now, if you look at the chart on the right of the slide, it shows you some of the primary functions of the office. And we won't go through all of them, but we'll just highlight 2 in particular. So one of our primary roles is to serve as a catalyst or convener of stakeholders to address disparities in health that racial and ethnic populations face. And so you'll see that as the green section of the pie, if you will. We also offer some small time-limited grants that are mainly for demonstration projects. And these help us to identify the programs, the practices, and the policies that can be adapted for use in other communities. And so you see that in the gray slice of the pie. Now, because the opioid epidemic is a priority for us within the office and within the department, we are supporting several demonstration grants to confront the impact of the crisis on vulnerable populations that we serve. Next slide, please. Now, many understand the opioid crisis to be largely a white rural issue. However, we're finding that the impact of the epidemic is indeed much greater than that. It is a nationwide problem that affects every community across our nation. Increases in drug overdoses have been so pronounced that they have contributed to reductions in the country's life expectancy, which has dropped for 3 consecutive years. And the drug overdoses are now the leading cause of death for Americans under age 55, as been reported by the National Center for Health Statistics. And so I'll say that again because that's really striking to me that drug overdoses are now the leading cause of death for Americans under age 55. So again, just one statistic that highlights the importance of the issue that we're here to discuss today. The data also show that racial and ethnic minority populations actually bear a disproportionate burden of the epidemic. While whites still make up a large portion of overdose deaths, the steepest increases in opioid-related overdose deaths are occurring among blacks. Minority communities in general across the nation also are being severely impacted by the crisis. Consequently, it is really, I'm really pleased to welcome you to the first webinar in our series that is entitled The Opioid Crisis and Racial Ethnic Minority Populations. Now, as we kick off the series, I think it's important to emphasize why this issue is so critical to address in communities of color. Next slide, please. So unfortunately, no racial or ethnic group has been spared by this epidemic. And let me just share an example of the impact on the American Indian and Alaska Native population, just as one example. In 2017, 11.4 million Americans misused opioids, with 11.1 million misusing prescription opioids and almost 900,000 using heroin. Among those individuals, American Indians and Alaska Natives had the highest rate of opioid misuse, and in this case related to prescription pain relievers and heroin. Also, American Indians and Alaska Natives also had the highest rate of prescription pain reliever misuse. Next slide, please. Now, the opioid crisis has been named the most critical public health challenge of our time because it unfortunately has taken a great number of lives. And again, here's an example of the impact of this on racial ethnic populations, this time related to African Americans. In 2017, more than 2/3 of drug overdose deaths involved opioids. From 2016 to 2017, the largest relative change in opioid-involved overdose deaths occurred among non-Hispanic blacks at just over 25%. Next slide. Now, different opioid types have driven overdose deaths over time, with synthetic opioids like fentanyl and heroin being involved in most deaths in recent years. From 2016 to 2017, for heroin-involved overdose deaths, the largest relative change occurred among non-Hispanic blacks at 8.9%. Now, if we look at synthetic opioid-involved overdose deaths, the largest increase occurred among non-Hispanic blacks at 60.7%, and American Indians and Alaska Natives at almost 60%. Next slide, please. Fentanyl has been a primary contributor to opioid overdose deaths. Among the over 70,000 drug deaths estimated in 2017, the sharpest increase occurred among deaths related to fentanyl, with more than 28,400 overdose deaths. From 2011 through 2016, blacks had the largest annual increase rate of drug overdose deaths involving fentanyl, with an increase of more than 140% per year. Next were Latinos, with an increased rate of overdose deaths involving fentanyl of more than 118% per year. Next slide. Opioid misuse is also associated with other health issues that are disproportionately impacting racial and ethnic minority populations. The national increase in infectious diseases is related to the country's opioid epidemic and associated increases in injection drug use. And we see this with infections such as acute hepatitis C infection, HIV infection, and endocarditis, which is an infection of the heart chamber and valve lining. Between 2004 and 2014, there were significant increases among Hispanics in both acute hepatitis C infections and treatment admissions related to prescription opioid injection. Next slide, please. The good news is that we know what works to treat opioid use disorder. Medication-assisted treatment, or MAT, using methadone, buprenorphine, or naltrexone have been proven to be both clinically effective and cost-effective. However, many persons with opioid use disorder do not receive this treatment. Even those who do receive treatment, even among those that receive treatment, many do not receive medication-assisted treatment. Treatment is especially underutilized by racial and ethnic minority groups. Among those who need treatment, only about 1 in 5, or a little shy of 20% of individuals overall receive opioid-related treatment. Asian Americans, Native Hawaiians, and Pacific Islanders with opioid use disorder are even less likely to receive opioid-specific treatment at only 1.24%. So think of that. So almost 20% overall, but with the specific Asian American, Native Hawaiian, Pacific Islander population, it drops to just a little over 1%. That is indeed a big disparity. A recent study showed that white individuals are almost 35 times as likely to have a buprenorphine-related visit than Black individuals. In addition, racial and ethnic minority youth under age 21 are significantly less likely to receive treatment for prescription pain reliever abuse and dependence than their white counterparts. Now, the reasons for low treatment use or differences in treatment among minority populations are many and include stigma, bias, cost of treatment, no or insufficient health insurance coverage, lack of knowledge about treatment, lack of culturally competent providers or culturally appropriate services, language barriers, and cultural attitudes about behavioral health. Next slide, please. There also are other considerations to note about the opioid crisis and racial ethnic minority populations, and I just want to outline 4 of these considerations. And there are more, but we're going to share these 4. Number 1, while we must improve pain management practices to prevent overprescribing, we also have to be very, very cautious of prescriber bias and be sure to not undertreat those who have legitimate pain, which should be addressed. Number 2, we should make sure our efforts and investments are targeted to optimize impact where it is most needed and to avoid inequalities. For example, as we've seen in the data thus far, there is clearly the need to target urban Black communities experiencing disproportionately high overdose death rates. Number 3, we should also pay attention to whether contributing and contextual factors, such as the social determinants of health, are present, because in those cases, different and more comprehensive strategies and interventions are needed. And number 4, the opioid crisis is indeed a complex problem that requires a multi-sectorial approach. Providers play a very important role in supporting individuals and communities by providing necessary treatment and services, addressing barriers and gaps, and serving as bridges to other partners. Next slide. So in closing, whether you are a physician like myself, or a nurse, a peer support specialist, a social worker, or any other type of provider or person that's interested in wanting to learn more, you play a very important role in addressing the impact of the opioid crisis in communities of color. In today's webinar, you'll have the opportunity to learn more about how to support better prevention efforts to keep people from misusing, becoming addicted to, or overdosing on opioids. In upcoming webinars, you'll learn how to improve access to and utilization of medication-assisted treatment for opioid use disorder, and how to use culturally appropriate care to ensure that culture and language are taken into account in providing high-quality prevention, treatment, and recovery services. Our hope is that you will apply the strategies, approaches, and tools that you will hear about in this series to help narrow the disparities gap for racial and ethnic minority populations. So thank you again for all that you have done and all that you will do in the future to help us combat this epidemic within communities of color. We at the Office of Minority Health want to partner with you to support you in these efforts, and so we invite you to stay engaged with us as we work together to move the needle on health equity in this area. And I want to especially encourage you to share your thoughts for actions and resources that will keep us moving forward in the evaluation survey that you'll receive. So again, thank you very much, and look forward to hearing all the good work that comes from knowledge you gain in this webinar and the other efforts that you will be undertaking.
Great. Thank you so much, Captain Collins, for providing that very important context for this webinar series. Next slide. And the next slide, please. I'm pleased to introduce our next speaker and the first speaker for today's webinar, Dr. Amy Goldstein, who's going to be laying some additional groundwork for today's webinar with a presentation on the principles of substance use prevention. Dr. Goldstein's chief of the Prevention Research Branch at the National Institute on Drug Abuse. She came to NIDA from MedStar Health Research Institute, where she was the scientific director for behavioral health research. And prior to MedStar, she spent a decade at the National Institute of Mental Health as the chief of the Preventive Intervention Research Program and the NIMH Associate Director for Prevention. So Dr. Goldstein, welcome and thank you.
Great, thank you. I'm happy to be with you this afternoon. You can go to the next slide. So this is just an overview of what I'm going to cover in my time with you today. I'm going to go through some general principles of prevention, give you examples of efficacious interventions for preventing the initiation of substance use, trying to highlight those that have been developed and tested with ethnic minority populations. I'm going to review some implementation frameworks and then talk a little bit about next steps for research related to the opioids. I'll say that, with the opioid epidemic, we still have some unanswered questions as to whether or not our existing efficacious prevention programs are effective in preventing opioid misuse. And we have some researchers that are currently looking into that, or if we need new programs that are going to be targeted specifically towards opioids. So I'm going to cover those general principles, and then I'll talk a bit towards the end about what we're doing here at NIDA to establish the evidence base that's more specific to preventing opioid misuse. Next slide. So for those of you who are not familiar, this is just an overview of different types of preventive interventions generally, and they're targeted towards an individual's level of risk. So for a universal intervention, everyone in the general population, regardless of your own risk level, is exposed to the intervention. So this might be a school-based or a classroom-based type of intervention. A selective intervention is delivered towards groups who are elevated risk, and that risk could be based on an individual, a family, or a contextual characteristic. So this might be targeting a child for intervention because their parent has a history of substance use. Indicated interventions are directed towards individuals who have actually begun using and are at high risk for transitioning to use or abuse, so kind of, again, a more targeted type of intervention program. And we're also exploring and studying tiered interventions. So those are interventions that incorporate 2 or more levels. So an example, going back to the school, might be where you have a school that's doing a whole school climate level intervention, and at the same time, they're identifying individual students who might be already initiating substance use and pulling them out for a more targeted intervention program. Next slide. So how do the preventive interventions work? So looking at this slide, we're going to start at the middle, where you see we have modifiable risk and protective factors. So we start with what we know from epidemiologic data for what is either a risk factor for initiation of use or something that protects against use. And what I have up on this slide are just sort of well-established risk and protective factors for substance use. So things like early aggression and early behavior problems, challenges with social skills, academic difficulties, association with deviant peers, neighborhood availability of substance, et cetera. And then you kind of look to the left where you see background factors. So these are factors that may predispose someone to being more or less susceptible to substance use or may moderate the effectiveness of an intervention. So we know that some interventions are more efficacious for males than females, for example. And then if you look to the right, what we do is try to develop interventions that explicitly target these risk and protective factors. And what I have up here are just examples of broad categories of interventions that have been developed. So you could target parent skills, social skills, self-regulation or impulse control in an individual, or kind of look at tutoring, norms training, et cetera. Next slide. And when we think about when and how to deliver preventive interventions, we really try to take a developmental life course approach. And this is a slide that was adopted from the work of Shep Kellum. And really what you do is you think about the different spheres of influence at which level you might want to deliver an intervention. So when you're looking at prevention in early childhood, you might look towards a family intervention. Then you kind of transition to middle childhood, elementary school. You look towards a little bit family, school, classroom, peers as the source of kind of intervention. And then as you transition into adulthood, you look at work environments, partners, a little bit family still, but more kind of community context. So I think this slide is important because it highlights, one, both your spheres of influence and where you might think about delivering or kind of laying a preventive intervention, but also it highlights transition points. And we think about transition points as opportune times for preventive interventions because they could be risk periods. So when you're transitioning from elementary school to middle school to high school, or kind of leaving the home, those are times of increased stress, increased transition, and a good time to think about prevention frameworks. Next slide. So kind of putting together what I've been describing, what you see here are examples of risk factors, protective factors, and the domain at which you might want to think about delivering an intervention. And kind of just the bottom line takeaway from this slide is when we think about doing preventive interventions, the goal is to really try to reduce the risk factors while we're elevating the protective factors. And you could have interventions that do one or both of those things, but this just sort of highlights overall, for example, at the individual level, you might want to try to decrease aggressive behavior while enhancing self-control. At the peer level, again, you kind of might want to decrease access or kind of association with deviant peers and access to substance use while kind of enhancing academic competence and pro-social peers. Next slide. So at NIDA, we have established this resource, which is called Prevention Principles for Early Childhood. You're able to access it from our website, and I have the web link up here, and I think these slides will be available so you can find it. But just some of the principles for intervening in early childhood. We know that intervening early in childhood can alter the life course trajectory in a positive direction. It can increase these protective factors and reduce risk factors, and have effects on a wide array of behaviors, even those not specifically targeted by the intervention. Next slide. So just to kind of show this from a data standpoint, this is some data on exposure to adverse childhood experiences. And we know that your early childhood experiences can impact your life course. And what this slide is showing you is retrospective data looking at around 8,600 individuals and looking at their exposure to adverse childhood experiences and early initiation of substance use, so use of illicit drugs as of age 14. And what you see is kind of the more adverse childhood experiences an individual had, the greater the likelihood that they'll initiate substance use earlier on. Next slide. But we have interventions that we can deliver very early on that can alter this course. So this is a slide that shows some data from the nurse home visiting program, which is David Olds' program. And what you find is this, when nurses visit with high-risk families, not even families, mothers during the prenatal period and then into early postpartum, this can have lasting impacts on substance use, mental health, and academics. So what you see in this slide here are effects at age 12 for people who participated in intervention when they were in the prenatal and early postpartum period. And what you find is that women who experience the nurse home visiting program, they have a lower percentage of children who use tobacco, alcohol, or marijuana at age 12. The children have higher reading and math scores, lower percentage of internalizing problems, and lower percentage of the moms reporting role impairment, again, 12 years after the program starts. Next slide. And I just want to highlight an example of a nurse home visiting type program adapted for American Indian Alaska Native population. So this is an intervention called Family Spirit that was developed by Allison Barlow and her colleagues at Johns Hopkins, and kind of an adaptation of the nurse home visiting program designed to enhance parenting and maternal life skills and prevent maternal substance use. And this is just going to be some data from their program targeting parenting outcomes, so parenting knowledge, parenting self-efficacy, and parenting stress for an intervention delivered by a well-trained American Indian paraprofessional. Go to the next slide. So this is just one of their findings. They have many, but this is focused on illegal drug use 3 years postpartum. So again, this intervention was delivered in the prenatal period. And what you see here, in addition to infant-level outcomes, which I haven't displayed, you see that there's at various time points differences in maternal substance use between the participants who received the intervention and those who didn't. So you can see specifically at 6 months and at 24 months, a lower rate of substance use from the parents who participated in this program. And results indicate impacts on infant well-being and provide support for the use of paraprofessionals for home visiting in American Indian communities. Next slide. So I touched on prevention principles that we have for early childhood. We also have a monograph that outlines prevention principles for drug use among children and adolescents. Just to highlight a couple of the takeaways from this monograph, which you can also download from our website. Universal interventions, we know that they have impacts on higher risk use, and they also have sustained effects over the life course. Prevention interventions implemented during earlier developmental periods have effects during adolescence and later stages. We know that there are crossover effects, so interventions targeting one risk behavior tend to have impacts on other risk behaviors that weren't necessarily the target of the intervention. And we know that preventive interventions and systems can reduce health and societal costs. Next slide. So this is a list of some efficacious interventions. I'm going to touch on all of them. I already mentioned nurse home visiting and Family Spirit. In the interest of time, I'm not going to give you a lot of detail on any one of these programs, just kind of highlight one or two findings from all of them. But I do have a resource at the end of the presentation where you can go to a website and download more information about some of these programs if they're of interest to you. Next slide. So this is data from Shep Kellum on the Good Behavior Game. So the Good Behavior Game is an example of a universal intervention. It's a school-based intervention focused on classroom management for teachers, administered in a randomized controlled trial in first and second grade in Baltimore. So the sample was urban, predominantly African American. And this is a slide that demonstrates some of the long-term outcomes of this intervention. So I wanted to highlight here a universal program with long-term effects. And what you find is you have on the bottom of the slide the teacher ratings of aggression, and then the likelihood that those individuals would engage in drug abuse or dependence. And this is at age 22 from a first grade intervention. And what you find are those that for males who are rated as highly aggressive in first and second grade by their teachers and then followed through high school, those who received the Good Behavior Game had less drug abuse or dependence in young adulthood than those who did not receive the intervention. And this finding was not true for females, so it was just a male effect. Next slide. Familias Unidas is a multi-level intervention that was developed specifically for Hispanic immigrant families with adolescent children. It was developed by Hilda Panton and Guillermo Prado. And it's a multi-level intervention that targets families, peers, and school. And the overall goal of this program is to increase family functioning. I just have one of their many findings up here, but what you can see is participation in this intervention reduced illicit drug use with a past 90-day reporting period. So what this slide demonstrates is the proportion of youth who reported illicit drug use in Familias Unidas decreased from about 30% at baseline to 22% 12 months post-baseline, where you can see it increased for those who received community practice or did not experience the intervention. So just an example of a finding that's specific to illicit substance use for Hispanic immigrant families. Next slide. The Keeping It Real program was developed by Flavio Marsiglia and colleagues, and this is a school-based program targeting Mexican heritage youth, and it was developed using a culturally grounded approach. And the REAL is an acronym that stands for Refuse, Explain, Avoid, and Leave. So it's a program that focuses on drug resistance, decision-making, self-management, social skills, and critical thinking. It's a 10-session classroom-based curriculum, which also has accompanying videos and a media campaign. Next slide. So this is sort of a complicated slide with lots of lines and colors, but I just want to highlight the takeaway point from this, which is this was an analysis that was asking the question of, does age of intervention matter? If we develop this program, does it matter when we deliver it? And the answer that they found was, yes, it does matter. When you compare the intervention being delivered in the 5th grade, so elementary school, versus middle school, they found a greater effect of the intervention for the middle school intervention as opposed to the elementary school intervention. So implementing the Keeping It Real program in middle school alone changed trajectories of substance use for all 4 substances assessed for Mexican heritage youth. So the earlier intervention didn't really matter as much. It seemed to be that the middle school age was a higher risk point, so delivering an intervention at that stage tended to have a greater effect for this population. So timing does matter when you think about preventive interventions. Next slide. Life skills training is an example of another middle school-based intervention developed by Gil Botvin. This is a universal approach, so everybody in a school or a classroom will be exposed to the intervention. And it targets drug abuse prevention by teaching skills and competencies to resist pressure to use drugs, so self-management skills, social skills, drug-related information, and the curriculum is implemented over several years, so elementary, middle school, high school, and then at the transition point. Next slide. And again, what you see here, again, making the same point that exposure to intervention is helpful. So looking at 6.5 years post-intervention, you see lower rates of drug use for the experimental group, so those who experienced the life skills training program, as opposed to those who didn't. So decreases in illicit substance use, heroin, hallucinogens, and amphetamines, 6.5 years post-intervention. Next slide. Another program I wanted to mention, the last one I'll mention, is the Strong African American Families Program. This was developed by Jean Brody and colleagues in Georgia. It was an intervention developed with rural African American families. And the goal of the intervention is to help the youth develop goals for the future, understand their own positive qualities, resist temptation for peer pressure, and also help the families to build a strong structure to support youth goals, enhance their families' racial pride, and strengthen family communication. Next slide. And while this intervention does have effects on behavioral outcomes, so those who are participating in the program had fewer conduct problems and slower rates of alcohol use and greater positive changes in their self-regulation, communication, and parenting, et cetera, I wanted to highlight actually what I think is a really innovative finding, which is the impact of the intervention on brain development. So what this slide is showing you is that more years in poverty is associated with decreased brain volume as a teenager. But what you see with this intervention, with the Strong African American Families Program, they were able to prevent that change in brain volume that you typically see with more years lived in poverty. And these are findings looking at volume of the amygdala as well as the hippocampus. So just kind of an interesting crossover effect showing the impact of a family intervention protecting against neurobiological impacts of poverty that could have on brain development. Next slide. The last program I want to mention isn't quite a program, but it's more of an environmental intervention. And researchers, Wong and colleagues at UCLA, asked the question of whether or not exposure to high-performing schools can improve health and behavior. So this is a natural experiment of a school lottery, where individuals who are from economically disadvantaged and minority settings in Los Angeles had the opportunity to go into a school lottery to attend a high-performing charter public school. Next slide. And what you see from their kind of naturalistic study of those who attended the high-performing charter schools versus not as a function of their lottery outcome, those who attended the high-performing schools experienced lower rates of marijuana use and misuse. So exposure to that high-performing school tended to have this protective effect And if you look at this slide in the graphic, to the left that favors intervention, you can kind of see that effect. So those who attended the high-performing schools tended to have lower rates of marijuana use, less risky peer networks, reduced truancy, and more supportive peers. So not a specific intervention kind of to target skills related to substance use prevention, but just an environmental intervention that had a protective effect. Next slide. So I just want to touch quickly on 2 implementation frameworks. So these are sort of shifting from talking about specific programs to talking about kind of a whole community approach to thinking about delivering programs. So Communities That Care is a program that was developed by David Hawkins, and it's a structure to kind of sustain multiple programs. So a community kind of does a needs assessment, develops a risk profile for their community, determines where they need to deliver interventions, and then implements and evaluates those programs. Next slide. So again, this is just to make the point that when you kind of take a whole community approach with universal intervention programming, you see effects on alcohol use, cigarettes, delinquency, and any drug use. Next slide. The PROSPER model is just another example of an implementation framework. Again, you have a prevention coordinator team that is a liaison between a state team and a local community team, where you again do kind of like a whole community assessment, and think about a whole community approach where you're kind of delivering different evidence-based interventions like the ones I've mentioned, but taking kind of a whole community systematic implementation approach. Next slide. And what we see here are, again, kind of these whole community implementation frameworks lead to improved outcomes and lower rates of substance use. So again, you can kind of see here that communities that delivered the PROSPER framework had lower rates of lifetime prescription opioid misuse and lifetime lower rates of prescription drug misuse overall. Next slide. So this is just a resource page. So I mentioned a lot of programs and not a lot of time. If you want to find the right program for your community or learn more about some of the programs I mentioned, these are great websites that kind of have registries and lots of program information and evaluation data for the programs I've mentioned. So you'll have these here. Next slide. And I just want to end by quickly referencing our U.S. Department of Health and Human Services opioid strategy. So we're really thinking here about better pain management, better targeting of overdose reversing drugs, better access to prevention, treatment, and recovery, timely and specific public health data, and better research on addiction and pain. Next slide. So just in terms of what we at NIDA are doing around prevention in the opioid space, we're really focused on that better research on addiction specific to opioid use disorder, including prevention approaches. And I just want to mention quickly the NIDA Rural Opioid Initiative. So this is an initiative co-funded by CDC, SAMHSA, and the Appalachian Regional Commission to really do a multi-site project in 2 phases where we're looking at community assessments in rural populations, and we want to implement evidence-based practices to address opioid misuse, particularly injection drug use, HIV/AIDS prevention, and related comorbidities. So we're trying to identify best practices to disseminate to rural communities. Again, trying to enhance use of MAT and screening and overdose prevention approaches. Next slide. And with my last slide, I just want to highlight some new directions for prevention research to address the opioid epidemic. As I mentioned when I started, we know a lot about preventing substance misuse in general. We know less about whether or not we need to target specific approaches in order to impact opioid use. So in terms of what we're doing here at NIDA in general, and specifically in the prevention research branch, one is we are testing the impact of these existing prevention models on opioid misuse, misuse disorder, and other consequences of opioid use. We're doing a lot more to intervene with providers and patients to reduce risk of opioid and prescription drug use. And we're evaluating the impact of state and local policies. So does use of prescription drug monitoring programs or prescription guidelines, when followed, does that impact rate of opioid use and misuse? And again, we're looking on research on community level approaches to reduce the risk of overdose. And we recently issued a funding opportunity announcement within the Helping to End Addiction Long-Term or HEAL initiative, targeting specifically at-risk individuals ages 16 to 30 in high opportune settings. So thinking about interventions in healthcare and justice settings in order to develop more targeted interventions to specifically address the opioid crisis. So we'll have more information and hopefully more findings on that in the months and years to come. So thank you for your time.
Great. Thank you so much, Dr. Goldstein, for that very informative presentation and for sharing a number of culturally tailored prevention interventions that are effective. Our next speaker, Dr. Donica Brown, is going to share best practices for tribal prevention efforts. Dr. Brown is a citizen of the Choctaw Nation of Oklahoma, born and raised in northern New Mexico. Dr. Brown has worked as a mental health and substance abuse counselor, social worker, and youth advocate for over 20 years. She has a history of working in the areas of prevention, drug and alcohol and mental health treatment, community and restorative justice, and sexual health with Native American and adjudicated youth. Dr. Brown, thanks so much for joining us today.
Thank you for having me. Halato Ochishioksoluba Ohilili Fiznik. Those are my names in the language of my people. And I'm really glad to be here. I'm chiming in from the traditional lands of the Multnomah Band of Chinook people known as Portland, Oregon. I'm currently the behavioral health manager with the Northwest Portland Area Indian Health Board. Next slide. And one of the things that I'm going to be talking about a number of things, but specifically I want to talk about and address culture in practice, how the Northwest Portland Area Indian Health Board is responding, and an overview of some of the best practices that we're seeing in the area. Next slide. The Northwest Portland Area Indian Health Board is a nonprofit organization that serves 43 federally recognized tribes in Oregon, Washington, and Idaho. And we house a number of different projects within our organization, specifically the Northwest Tribal Epidemiology Center. We have an advocacy program, and we also house the Northwest Indian Health Service Institutional Review Board. And with under that, those programs, we have a number of initiatives, including a tribal opioid response project. Next slide. Everything that we do at the Northwest Portland Area Indian Health Board is grounded in culture, specifically integrating culture into the practices that we do. And through that, some of the considerations that we take in developing programs is understanding historical and intergenerational trauma, understanding the diversity of tribal communities, being connected to and involved with tribal community and tribal agencies, and their councils, and understanding and respecting the sovereignty of the 43 federally recognized tribes here. When we do this kind of work, we really want to be centered in those specific things, and understanding that it's the culture from these very specific communities that brings strength to the interventions that we do. Next slide. So a number of years ago, the Northwest Portland Area Indian Health Board conducted a needs assessment within our community, and we interviewed American Indian people who inject drugs. We had 32 interviews, and through these interviews, there were 8 themes that came up with these participants regarding injecting drugs and their drug use in particular. And some of those issues were stigma, harm reduction, access to harm reduction services, negative perceptions of treatment services, barriers to treatment, at-risk behavior, inability to access unused syringes. It was challenging for them to achieve sobriety, and tribal council policies and outlooks on injection drug use. Next slide. We then took this information and went to the Harm Reduction Conference Roundtable. We hosted a roundtable at the Harm Reduction Conference. And there were 2 primary recommendations in that. There were national policy suggestions and then tribal policy suggestions. And so many of the national policy suggestions are revolved around funding, access to funding, legal considerations, allocation of existing resources, and indigenizing programs, and a number of other suggestions. The next slide. For tribal recommendations, really the focus was around this theme about nothing with us, without us approach. So the recommendations revolved around programming, again, tribal legal issues, and leadership considerations within tribal communities. Next slides. So out of those roundtables, we developed kind of a 3-tier process for addressing these issues within the Northwest Portland Area Indian Health Board member tribal communities. And the 3 projects that we developed out of that information was a tribal opioid response that is funded through SAMHSA. And we did a consortium of 22 tribes that the board applied for to help those tribes get those funds, and then 13 tribes applied on their own. Many of the tribes that we developed the consortium with just did not have the internalized capacity, institutional capacity to apply for and manage those tribes or manage those grants. So we applied for that funding for them, and all of the funding goes straight to the tribes for them to help to develop those programs. And then, like I said, 13 tribes applied on their own. What I understand is that SAMHSA funding, they were expecting a number of tribes to apply, and were surprised when only 130 plus tribes applied for that money. So when you put it in perspective, 130 plus tribes applied for that money. 35 of those tribes are in the Pacific Northwest. That's how much of an issue and concern and priority opioids are, this opioid crisis is in the Pacific Northwest. The next initiative is the Indian Country Substance Use Disorder Echo Clinic, which is also funded through SAMHSA and OMH. And these clinics are specifically around medications for addiction treatment in primary care, so it's a focus on MAT treatment and interventions. The last program we proposed is developing a strategic plan to address the opioid epidemic, and that project's funded through the CDC. Next slide. So the the Tribal Opioid Response Consortium, the overreaching goal is for the board to develop a comprehensive strategic approach to assist tribes in developing and addressing the complex factors associated with a comprehensive opioid response. Our primary goal is to deal with the structural disaggregation of necessary OUD treatment components in the Indian healthcare system, and provides tribes and clinicians with comprehensive information to do more for our patients and system. The Northwest Portland Area Indian Health Board aims to address the opioid crisis in tribal communities by increasing capacity to address the complex factors associated with a comprehensive opioid response. Part of this is addressing kind of what we're viewing as reframing the opioid crisis within a tribal or indigenous framework. So the way that we kind of frame this is by understanding that substance use disorders in particular, but opioid in particular, is not a tribal value. And we kind of reframe this understanding of the opioid as a trickster spirit. So in our tribal, within our traditional knowledges, we have these understandings of different relationships to medicine. And so for us, when we think about opioid abuse and use or misuse in that context, opioids in particular are like a trickster spirit. It's an original medicine that helped us to be healthy and happy and not suffer, but at some point it gets twisted up into something that is like very primitive, and it gets twisted into something that's not helpful and not healthy. And particularly, I frame it as a coyote spirit. When you think about coyotes, they're these kind of savage scavenger animals that are scavenging for survival. And so we reframe that and talk about it within a more tribally appropriate context. Next slide. One of our kind of gleaming best practices that we want to share is a program that was developed in Washington called the Swinomish Integrated Care Project. And it's pronounced Dewallich. And Dewallich is an interesting program. It's based on the Johns Hopkins model, where they have addressed every issue that that community has brought forward as far as why people are not accessing substance use treatment. And so within this, the tribe donated the money to build the facility. It's all in one location. They built this beautiful facility that's based on their tribal understanding of community, and they built a longhouse, and everything within the needs of the community are met within that longhouse. To address some of the barriers of care, one of the significant issues the community said, and we all know this in many communities, is around transportation. So the first thing they did was develop a fleet of buses that go out into the community and pick people up and bring them on into the facility for care. The other issue is they have on-site child care. They have a comprehensive case management program with a clinical social worker. They have parenting classes. They have life skills development. They also provide assistance for housing and other basic needs. They also utilize medicated assistant treatment. They have coordinate with methadone clinics in the area. They provide Suboxone prescriptions. They have drug and alcohol professionals on staff. They provide mental health treatment and other counseling services, and this is integrated with their primary care. They also provide other services, including traditional medicine and traditional ceremonies in the community, and access to those. They also have an acupuncturist and a massage therapist on site as well. Next slide. So as you know, this is kind of an ongoing issue within our communities, all of our communities, is that we have more patients with substance use disorders than we have providers or treatment centers, and many times those treatment centers have long waiting lists. At Dewallich, there is no waiting list. They've been able to provide a number of drug and alcohol providers to assess the need, and there is no waiting list. The other thing is that when you come into the facility, there is a person at the front who acts as the receptionist. When you come in, she knows your name. She knows who your family is. She offers you coffee or tea or something to drink. When you come into the facility, it's an open and welcome place for all people who need support and help. Next slide. So this is a really beautiful and wonderful example of how to integrate culture into a community practice. The other practice we would like to highlight is our Indian Country Echo Project ECHO stands for Extension for Community Health Outcomes. And this is a collaborative model of medical education and care management that enables clinicians, regardless of where they live, to provide better care to more people right where they live. This also addresses that other issue of having not enough providers. And so this is essentially an online telehealth community where we can provide supervision and support to those tribal communities that don't have that kind of support. So this is funded through both OMH and SAMHSA, and participants are divided by states, so there's no overlap in funding. The ECHO model doesn't actually provide care to patients. Instead, it increases access to specialty treatment in rural and underserved areas by providing frontline clinicians with the knowledge and support they need to manage patients with complex conditions, such as hepatitis C, HIV, tuberculosis, chronic pain, as well as a number of other disorders. It does this by engaging clinicians in a continuous learning system and partnering them with specialist mentors and colleagues. The kind of secondary aspect of this that we found is that a lot of tribal people who are working in tribal communities don't feel like they get a lot of support. And so this ECHO, the substance use ECHO in particular, has been a space where people who are serving tribal communities have a community of their own. They come into that space, they know each other, they support each other. A big aspect of this is that we acknowledge and support the very complicated cases that they're engaging with, but we also provide we provide a space for clinicians to get emotional support as well. As you know, we many times are overworked and stressed in dealing with these very complicated cases and don't get a lot of emotional support. So this is a secondary aspect of this program that we are seeing in our communities. So consequently, we started with 2 substance use echoes a month for an hour a month, and we're already have a backlog of cases that need to be supervised, and so we're looking at increasing the number of programs that we're doing and the number of times that we're implementing those. Next slide. You can go to the next slide, sorry. So Indian Country Substance Use Disorders echoes, the overall objectives include expanding MA2 services to at least 60 clinics and providing data waiver 2,000 training to at least 75 clinicians, and to provide consultation to at least 175 American Indian and Alaska Native patients. We started this project in January, and I think that we've already exceeded expanding our MAT services to 60 clinics, and we definitely have already trained more than 75 clinicians in data waiver training. And I don't know the numbers, but we are definitely well on our way to providing consultation for over 175 patients. Next slide. So use of medications like buprenorphine, methadone, and naltrexone to treat opioid use disorder is now considered a best practice, and states are increasingly requiring treatment programs to offer medications for opioid use disorder in order to participate in Medicaid programs or SAMHSA funding. One of the barriers that we've been having in tribal communities is that many tribal communities or organizations that are serving tribal communities have really heavily relied on sobriety-only programs or abstinence-only programming. So one of the things that we've been really working with is helping tribal communities understand that our ancestors would want us to use every tool in our toolkit to alleviate the suffering of our people in this generation. And so we talk a lot about that with them and help them understand that MAT, along with behavioral health services and along with providing a continuum of services to our communities, is actually more of a traditional practice, that we want to be able to alleviate the suffering of our communities and our people. We do know now that opioids in particular alleviate pain, and that pain, both emotional and physical pain, processes itself in the brain the same way, and that opioids alleviate that. So a significant part of this is understanding the historical trauma and current trauma and intergenerational trauma that impacts our communities, so that we can best serve them and alleviate their pain and suffering, so that they can access and become vital, important members of our community. Next slide. So the current opioid Project ECHO curriculum design and learning objectives are as follows. At the conclusion of the curriculum activities and through the process of ECHO telementoring, participants will be able to demonstrate the following competencies: understanding the basis of MAT and how it fits into addiction treatment, describe options for opioid detoxification, to understand the unique properties of methadone, buprenorphine, and naltrexone for opioid use disorder, identify and understand the strengths and weaknesses of MAT, provide resources for providers to provide a neurobiological framework for understanding for our patients with chronic pain, addiction, and trauma, and understanding new concepts in neurobiology and addiction for chronic pain. Next slide. One of the other programs that I wanted to highlight, and I don't have a slide for this, is that, you know, some of our tribes who have historically been significantly impacted by opioid-related deaths. There's one tribe in the Pacific Northwest who, in 2016, I believe, had 11 deaths of their tribal citizens to opioid overdoses. At that point, they made a decision within their community to address this from the top down, and the whole community made a commitment to addressing the opioid crisis in their community. They made significant policy changes within the community from the top down to address this issue. They've trained every single person, employee in the tribe, on how to implement naltrexone, and they give it freely out to anyone in the community who wants that training, and everyone has access to it. They also implemented a Good Samaritan law within the tribe so that people who intervene on an overdose will not be investigated in any kind of crime in that. The other thing that they've done is that they've been addressing the tribal members who are dealing the drugs on the tribe within a tribal traditional viewpoint, and have engaged in some traditional banishing of those people from their communities. And so they're engaging on a level. Last year they had one overdose death from an opioid use. So they went from 11 deaths to 1 death last year. Unfortunately, this year in April, they had 6 deaths from an opioid overdose. And I think they believe that there was some bad heroin that came into the community and that's what impacted that. So they're still investigating that phenomenon. But this tribe may be one of the first tribal communities or community at all that might go to a zero overdose death rate that we've seen. And so, you know, the other aspect of what they've done is they've increased access to cultural activities for those people who are suffering from substance use disorders. Whereas some communities have said if you are using or high at the at the time, you're not able to participate in cultural activities or events. This community has said even if you're high, you're welcome to come, and we're going to take care of you, and we're going to support you in getting sober or getting, addressing their misuse. So for us, we have shown that research has shown that the most effective treatment providers are those who are fluent in many theories and models of treatment, who are client-centered and counselor-driven, that we focus on strengths and protective factors, those who are able to develop trusting therapeutic relationships with clients, and who work within their area of expertise. We at the board and many of our communities believe that culture is prevention and culture is healing. And so we work very hard to engage and develop interventions, prevention and treatment interventions that address the culture that is centered into that. And that these programs address historical and intergenerational trauma. That's the end of my presentation. We'll take questions at the end. Thank you for your time.
Thank you so much, Dr. Brown, for sharing those exciting efforts and all the special considerations for tribal populations. So our final speakers for the day will be Dr. Ingrid Binswanger and Dr. An Nguyen to share lessons learned from their research on overdose prevention. Dr. Binswanger is a senior clinician investigator at the Institute for Health Research and a practicing physician in chemical dependency treatment services with the Colorado Permanente Medical Group at Kaiser Permanente, Colorado. She's also an associate professor in the Division of General Internal Medicine and an affiliate member of the Division of Substance Dependence at the University of Colorado School of Medicine. Dr. Nguyen is a postdoctoral research fellow at the Institute for Health Research. He received his doctoral degree in sociology from the University of Michigan, and his current research examines the consequences of exposure to opioids in the family on youth risk of overdose. So thanks so much, Dr. Binswanger and Dr. Nguyen, for being with us today.
Thank you for the opportunity to share our research today. Next slide, please. So as an overview, we'll first provide context on the criminal justice system, substance use, and racial disparities. Next, we'll share lessons learned from our research on recently incarcerated individuals. And then finally, we'll describe a patient navigator pilot and how that might serve as a strategy to reduce health disparities. Our presentation today will focus on criminal justice populations, but we believe that there are important lessons from this high disparities population that can be applied more broadly to racial and ethnic populations to reduce disparities. Next slide. We also believe that focusing specifically on the criminal justice system can help address opioid-related disparities for several reasons. The first is that this is a large and revolving population due to repeated contact with the criminal justice system. We know that there are high disparities because minorities are more likely to be touched by the criminal justice system. Their substance use is also very common, and rates of fatalities are also high. Criminal justice transitions can also put individuals at increased risk for overdose. And finally, there are social and economic barriers to the healthcare and treatment for this population. Next slide. First, we'll start with some context on criminal justice context and disparities. Next slide. Over the past 4 decades, there's been a dramatic growth in the correctional population, so that by year-end 2006, there's consisted of nearly 7 million adults. Next slide. Next slide, please. We know that this growth has not been evenly distributed. Minorities are more likely to be touched by the criminal justice system. So, for example, the imprisonment rate is highest for Black men, and this is twice the rate for Hispanic men and 6 times the rate for white men. Next slide. Substance use is also common in criminal justice population. Based on data from our research in Michigan, we know that over half of individuals in the criminal justice population report any drug use history, and nearly 7% overall report daily use of opioids. Next slide. There's also a high burden of mortality in this population, particularly in terms of overdose deaths. Again, from our research in Michigan, we find that while this population represents a small fraction of the overall state population, overdose deaths account for more than 11% of all fatal overdoses in the state. Next slide. So now with that context, we'll turn to our research on overdose risk and prevention among recently incarcerated individuals. Next slide. We know that prison casts a long shadow, and there are numerous challenges during reentry that could put individuals at increased risk for overdose. There are significant barriers to housing and employment, due in part to the mark of a criminal conviction as well as time in prison. There are also challenges reintegrating with families and communities, and we know that because of the lack of safety net, individuals must rely on families for survival, but at the same time, time in prison could put a strain on those relationships. Individuals must also abide by stringent parole supervision requirements, and any violation of those conditions could put them at risk for future imprisonment. And finally, we also know that many will grapple with drug and alcohol use disorders. Next slide. So in addition to the challenges of reentry, we know that criminal justice transitions can aggravate health disparities. We know that there's stress and stigma associated with incarceration, and challenges with employment and housing can directly impact health. Multiple transitions to the criminal justice system could negatively influence care and continuity of that care. And at the same time, we know there are limited access to care and poor quality of care, particularly for treatment for substance use disorder and mental health treatment. Next slide. So based on prior research, we know that there are key risk factors for this population that include psychiatric disorders, especially panic disorders, substance use disorders, problems with opioids and sedatives, as well as history of injection drug use. There are also known protective factors, including having children, increasing years of incarceration, as well as access to substance use treatment while in prison. Next slide. Based on data in Washington State, we know that drug overdose is the leading cause of death after release from prison. And here we see that overdose deaths are more than 10 times what we would expect for a similar population in the general population. Next slide. And we know that the time immediately following release is the most high-risk period. And again, this emphasizes the critical period for intervention, especially around transition. Next slide. We also find that opioids are the leading substance involved in overdose deaths after release. And we find that overdose are involved in 15% of all deaths after release. So now we've shown that recently incarcerated individuals face high risk of overdose after release. Next slide. So now I'll turn it over to Ingrid, who will talk more about what can be done to prevent overdose deaths in this population.
Great, thank you. So, what we've learned from some of this research is that these times of transition, when people move between one system and another, are particularly risky for overdose. And there's lots of transitions that vulnerable populations may face, either between after a hospitalization, after a criminal justice stay, say in a prison or a jail, but also after other transitions such as insurance loss, job losses, or housing instability. And these could all present potential barriers and increase the risk of overdose. Also, if opioid use disorder is not treated, there's a high fatality rate, and there's a lot of social and economic barriers to healthcare and treatment that vulnerable populations may face, such as those engaged with the criminal justice system. As a result, we need some interventions that can work across these multiple domains and address all of these issues to get people to the evidence care that they need. Next slide. Oh, I think I just lost the, I can't see the screen. Let me just, let's see. So there's been, is this the one that says high mortality rate?
Yes,
Hello?
it is.
Okay,
Yes, it
great.
is.
Excellent, thank you. Sorry, I'll just have to work off of, I'm not sure why. Maybe On can help me reconnect with the screen here. Give me one moment. What happened? I'm having a technical problem. Okay, there we go. Now I found it again. Got it. Thank you. So there's in the general population, we know that there's very high mortality rates from opioid use disorder, especially when it's untreated. So there was an international meta-analysis that was published in 2011. That one showed that the mortality rate among individuals with untreated opioid use disorder is about 2 per 100 person years. And I often share that number with my patients to say that untreated opioid use disorder is associated with about a 2% per year risk of mortality. The highest risk is from overdose, although as we've already heard, that there are also risks associated with infectious, such as hepatitis C and infective endocarditis. The risk overall is about 15 times higher than in the general population if you have an untreated opioid use disorder. We unfortunately think that these risks are going up even higher as the opioid epidemic evolves from being predominantly focused on pharmaceutical opioids, where the case fatality rate in our system at Kaiser was 10 fatalities from overdose for every 100 of fatal and non-fatal overdose, to increasing to 38 when it's fatalities for every 100 fatal and non-fatal overdoses, to a rate that's probably even substantially higher with the potency of fentanyl. That's probably, I would expect, around a case fatality rate that might be higher than 50. Next slide. We also know from the general population literature that being out of treatment is associated with a substantially higher risk of mortality than being in treatment. So being out of treatment off of medications is associated with about a 2 times higher risk of mortality, almost 2.5 times higher risk of mortality than being in treatment. And the longer you stay in treatment, the better your survival. There are, however, some cautions to this. The very initiation period of treatment, starting medications, the induction period with buprenorphine or methadone can be associated with a bit of a higher risk. So that is a period when people might still be using other substances as they're trying to start treatment. So that's a particularly vulnerable period. And then soon after discontinuation of treatment, if people do decide to stop medications, that is also associated with high mortality from overdose. Next slide. So some of the ways that we prevent opioid overdose deaths are evidence-based treatment, including pharmacotherapy with methadone, buprenorphine, or naltrexone. Also overdose education and naloxone, which is a shorter acting opioid antagonist that can reverse all of the signs of respiratory depression associated with an overdose. It's sort of a rescue medication. And in addition to providing access to these medications, we have to address system linkages, how to link people with the systems that can provide them with that care, and also their psychosocial needs in order to help them stay engaged in care. Next slide. Next, please. Next slide. So we developed a patient navigation intervention to address the needs of individuals in the criminal justice system, particularly individuals in that vulnerable post-release period. We tried to target the intervention to individuals at the most vulnerable time, which is really the first 14 days after prison. And we tried to place the intervention in the context of a large number or several other issues that need to be addressed in order to reduce population health disparities with criminal justice populations, which includes screening and providing early intervention for infectious diseases, screening for cancer, improving health literacy, and helping individuals gain the skills they need to navigate a very complex healthcare system, as well as ensuring that they have access to quality care. Next slide. We used an extensive literature to guide the development of this intervention that's been done on patient navigation and cancer screening for Latino populations, and also evidence from the Transitions Clinic Network, which is a large network of clinics where they're treating individuals or helping to link people with criminal justice involvement with the healthcare system. And our goal here was to try to test the feasibility of this intervention during the very acute post-release period where people are at highest risk for overdose. We wanted to reduce their barriers to treatment and also general medical care, and also reduce their emergency department visits and hospitalizations. Next slide, please. We were able to recruit 40 adults for this small trial. We got them in the first 14 days after their release. It was a high racial and ethnic minority population in Colorado. They had a history of a drug-related offense or a lifetime history of substance use disorders, and they were individuals who'd experienced many barriers to substance use disorder treatment, like those we've already heard about, such as financial barriers, insurance barriers, transportation, and knowledge barriers. We recruited them from the Denver Community Reentry Services Center, which is a branch of parole. Next slide. We provided both of the intervention arms assistance with linking to the Colorado Indigent Care Program, which is a subsidy program for hospitals that serve indigent patients. So both groups received basically the normal things that they would get in and supervision that they would get in parole, plus they both got the Indigent Care Program. In addition, the Navigator group got patient navigation, which I'll describe on the next slide, please. The Navigator was a lay person who'd had a family member who'd been involved in the criminal justice system. He was based at the Community Reentry Services Center, but he was also employed by Denver Health, which is our safety net community hospital. So he was able to access patient charts and help them schedule appointments at Denver Health. He was formally trained in the Colorado Patient Navigator program. He assessed their medical, mental health, and substance use disorder treatment needs. He helped them coordinate their refills and patient appointments after their release from prison, provided social support, and tried to communicate with our participants about every week in person, at least, via phone or text. Next slide. This is a description of our study design. You can see we recruited people and randomized them. We then gave them 3 months of patient navigation or the control arm. And follow-up was very complicated, which sort of describes demonstrates the difficulty in working with this population. At 3 months, 15 had been reincarcerated. At 6 months, 15 were reincarcerated. That was another group of 15 individuals. And we analyzed the data regardless, and were able to do follow-ups with a number of the patients, both using electronic data from the electronic health record, as well as surveys. Next slide. What we found was that both groups, the intervention and the control arm, experienced reductions in the number of barriers to substance use disorder treatment services. Both groups experienced good increases in enrollment into the Indigent Care Program. And interestingly, we found that the intervention group had reductions in, the control group had higher reductions in the number of emergency department visits and urgent care visits than the intervention group, but the intervention group had fewer hospital stays. It was a small study, but we think that the reason this is that the navigator often had to navigate people to the emergency room in order to help them get access to life-saving treatments that they weren't receiving before. So say we had somebody who had a substance use disorder and diabetes, we were able to navigate them and help them get their insulin refilled at the emergency department. So we did see some increase in emergency room use, but we saw reduction in hospitalization. So for a small pilot study, we were quite pleased about that result. Next slide. So even though it's very complex to follow up with a population that has as much instability as criminal justice populations, we think patient navigation is a promising approach to help overcome the barriers to evidence-based medications for substance use disorder, and to help improve outcomes such as hospitalizations and overdoses. We hope that this type of intervention could be tailored to address cultural and linguistic differences for racial and ethnic minority populations and for individual communities where patient navigators are hired from those communities to deliver the services. Next slide. So in summary, minorities bear a disproportionate burden of criminal justice contact, and there's a lot of stigma associated with the criminal justice system, but it's perhaps one of the most at-risk populations for some of the complications of opioid use disorders. There are significant social and economic barriers that need to be addressed to get both prevention efforts for overdose as well as general medical needs met. And we need interventions that specifically focus on reducing some of the barriers to those needs being met. Some of the interventions that are needed may also that can also be delivered, such as patient navigation, can also hopefully improve population health and help address the opioid epidemic and racial disparities in health outcomes. Thank you. That's it.
Thanks so much, Dr. Binswanger and Dr. Nguyen, for sharing these findings from your research in the pilot program. And also, I want to thank all of our presenters for taking the time today to share their expertise with us. We hope that all of the participants on our webinar found the information useful in the work that you do. There have been a number of questions that have come through our chat box, and I just, since we're running short on time, I just want to let folks know that we'll make every effort to record those questions and to follow up via email to answer those questions. But now with the few minutes that we have left, I want to try to squeeze in some answers to a few of those questions that we've received. So the first question has to do with those specific risk factors for substance use among racial and ethnic minority populations, and how racism, how and if racism is a contributing factor. So I'll also expand on that question to ask if there are other risk factors for substance use or opioid misuse and addiction that are specific to racial and ethnic minority populations that the presenters might share.
Sorry, I realized I'd muted my phone and you'd muted me. So this is Amy Goldstein. You know, I'll say in terms of specific risk factors for opioids, you know, I think we're still looking to fund some of that epidemiologic work to look at kind of the patterns of use and where there might be risk factors that are different for initiation of this substance as compared to others. You know, I think we can kind of see some differences, at least in terms of, you know, there's kind of more initiation starting from prescribed medications. So thinking about how we might want to intervene in a healthcare setting different than we would in a school setting. But I know at least on the NIDA side with some of the work we've been trying to support and, you know, kind of solicit from investigators, it is to look more carefully at what the risk and protective factors might be specifically for opioids.
Yeah, this is Ingrid Binswanger. I would just say that, you know, probably many of the risk factors are similar across different populations, but I think that if you've been exposed to poor access to healthcare generally and poor access to substance use treatment or lower quality substance use treatment without having access to sort of evidence-based medications and continuity of care, that you're likely to face more of these vulnerable transitional periods where, say, you've been on a medication, this is more a little bit tertiary prevention, but say you've been on a medication for a while and then it suddenly stopped because you lose insurance, that could be a risk factor for having an overdose then, for example, because there's just more burdens of poor continuity and access to care. And you may not have access to early intervention or early screening and brief interventions to help prevent substance use. So that, I think, probably many of the pathways to increased risk sort of follow issues related to poor access to care.
Thank you, Dr. Goldstein and Dr. Binswanger. This is a question specifically on Project ECHO for Dr. Brown, wondering how the sessions are managed. So specifically, who are the presenters, and are they local to the Indian country community, and what level of participation are you from tribal communities on an ongoing basis versus only one session?
So the ECHO panel, we usually have a medical provider who is a specialist in addictions. We have a pharmacist who's a specialist in addictions, me as the social worker. We have a peer support specialist, a person who's in recovery from opioid use. And then let me see who else. That's about it. Oh, and then we have a psychiatrist who also specializes in addictions. So that's the panel. The peer specialist and I are the only Native American people who are on the panel. And so we provide that cultural context. The ECHO, we have, generally speaking, between 10 and 20 people come into the ECHO. We also open up, when we do the clinical portion of it, we have a form that they fill out with all of the kind of specific details. We ask people to share any other information they have about the patient. And then we actually open it up for questions from everyone who's in the ECHO, and then the panelists ask questions. And then we open it up to everyone in the ECHO to provide recommendations for the patient, and then the panel provides recommendations to the patient, and then we follow up with a written report to the clinician. What was the other part of the question?
It was, what level of participation are you receiving from tribal communities on an ongoing basis versus only one session?
Ooh, that's a good question. I can only kind of go by I don't have hard numbers on that, just from my experience. We have a number of tribal communities that come on every single time. I would probably say, or regularly, not every time, but regularly, I would say, and this is a guess, probably 2/3. And then 1/3 are the people who just come on once. That's completely just off my top of my head from my experiences, but I'm sure we do have those actual numbers. Was there another part of the question? Sorry.
No problem. I think that was it.
Great.
And I'll just go ahead now and bring us to a close for this webinar on the final slide. So I just want to thank everyone again for your participation today and for a great discussion. And I also want to invite you to subscribe to our newsletter, visit our website and our social media accounts to stay engaged with the Office of Minority Health. Again, we'll do our best to follow up with all of the questions that were submitted via the chat box, through email. There seem to be a number of questions related to treatment, so I just want to make a special plug for our next webinar, which will focus on treatment, and I hope that you all can join us for that. Please take a few minutes to complete our evaluation survey, which should pop up on your screen once you exit. But if not, you should also receive the survey as well as a recording of the webinar within 24 hours by email. And again, just want to remind you, if you want to request a copy of the slides, you can email info@minorityhealth.hhs.gov. Thank you again for joining us today. We hope to see you on the next webinar in our webinar series, and have a great afternoon.